our next speaker is Mr. Rizwan Hamid. He is consultant urologist, University College Hospital and London Spinal Injuries Unit, Stanmore. He will be talking about bladder management after spinal cord injury, or guidelines, the true standard. Dr. Hamid, please come on the stage.
Thank you, Mr. Chairman, for the kind introduction. I think it's becoming a cliche, but I will add my gratitude and say that it's a privilege to be here and invited to talk to the colleagues, obviously both from Pakistan and the UK. Mine is actually more of a clinical talk, and I know there are only a few urologists here, but generally looking after spinal cord injury patients is quite a holistic approach is required. These are my disclosures. The management of spinal cord injury actually has been revolutionized since World War II. Since that time, what people found out was that you need to have a holistic approach, a comprehensive care if you want to treat a condition which affects whole of the body instead of just one system. The complexity then is that it is already well in developed countries, but there are a number of studies showing that that is not the case in low and middle-income countries, or otherwise you can call them as underdeveloped countries. And that still poses a big challenge in managing spinal cord injury patients in these countries. And unfortunately, these patients have not been able to gain the same benefit from the technological advancement and what we call as an MDT approach. If you look at the world map, the spinal cord injury actually afflicts people from all over the world, no matter where they are living, and they're kind of the causes are more or less equally distributed. But here stops the commonality, because if you look at the studies, if you look at prevalence, incidence, what the symptomatology is, but going on to see the survival, all the studies, or almost all the studies, are from the developed countries. That begs the question that how do then all the research and all the guidelines which are actually developed by the for the patients in the developed countries, by the physicians in developed countries, can they be transposed to the underdeveloped world? The reason is why we are so fixated with spinal cord injury and the bladder is, well, initially when the spinal cord injury happened, the top cause of death was actually the renal failure. And if you now look at the causes, this has dropped down to 5 or 6. And the reason for that is that we have now understood that not only the spinal cord injury, but also spina bifida patients, what happens is that the bladder is a dangerous organ if it is not emptying very well, and that can affect the upper tracts. So we need to have an algorithm how to treat these patients, and this is where the guidelines come in, that you need to protect the upper tracts, quality of life, and cure their incontinence. And how we do with that? It is done by these 3 things, that we investigate those patients, have a treatment protocol, and then follow up these patients. So when you are having a look at the diverse group of patients, what is the best way to do that is to collect the evidence, formulate some guidelines, and then treat patients according to those guidelines. And if you look at the guidelines in urology, they are from the European Association of Urology, they are American guidelines, these are the international guidelines from ICI and ICS. And in the UK, we are very privileged to have actually nice guidelines which not only look at the evidence, but also look at the cost effectiveness of that evidence, and then issue the guidelines. So do we have to follow these guidelines? Well, on the face of it, the obvious answer is yes, probably we should follow the guidelines. But when you dig deeper and see what exactly are the guidelines, actually there are recommendations regarding the clinical behavior. And they're depending on a host of factors, from who the guidelines are written for, what is the social, occupational, economic, and political context. And actually, issuing guidelines is one thing. How do you implement them? And can you police implementing the guidelines? As there's quite a lot of evidence in literature that actually guidelines are not very well followed, and not only from the patients, but also the doctor's point of view, and they're quite subjective. A lot of factors come in from knowledge, attitude, skill, experience of the patients and the physicians, and also what the beliefs and the values are. What is not written here is the financial and the political aspects come in, and what the setup of the hospital is, whether the guidelines can be implemented or not, and that's what we see in generality. Coming back to the bladder guidelines in neurourology, if you look at those three blocks, the investigation, treatment, and follow-up, as far as the investigations are concerned, all the guidelines, the gold standard is urodynamic studies to investigate a neuropathic bladder. And when you look at the guidelines, it's not come out actually very well. It says offer videodynamic investigations to all the people who have got high risk of renal complications. Those were the Western guidelines from the Western world. If you look at the ICI guidelines, which are more international, it actually says the same thing is that the guidelines should be, that the urodynamics should be undertaken in neurological patients. So all the guidelines recommend invasive urodynamics. But it is how you look at the guidelines. Are they really evidence-based? And do we really have to follow them? And why we need to do urodynamics? And when you dig deeper, it is to make the diagnosis, to consult the patients regarding complications and the outcomes. You want to manage their expectations, but also you want to make a correct diagnosis both for the patient and yourself. And one thing which is overlooked, and maybe it is the most important thing nowadays in this litigious society, is that are we doing investigations for medical legal reasons, and we need to do that more in the Western world than in the underdeveloped world. So then, are we treating the investigations, or do we want to treat the patient? Or actually we are trying to do it for medical legal purposes? It's all very well to look at the guidelines, but sometimes you can get some information from the published literature which is outside the guidelines. And this is a study which I did a number of years ago, and this is a follow-up. If you look at the guidelines, this is from UK and Ireland, and although the EU guideline says that it should be done every year, but the urodynamics are not done by the units in the UK and Ireland. And the reason I've put this up is that the local guidelines say that it can be done. So sometimes you don't have to follow the international guidelines, but the local guidelines needs to be developed, and you can modify the international guidelines as per the local needs. This is again a paper which says that the urodynamics, which the guidelines says should be essential, is only needed when it is required in specific situations. I did mention that NICE guidelines are the ones which actually take into cost implications also. And like NICE guidelines say that investigation-wise, we do not need to do for all patients. It should be only done for patients who have got a high risk for developing complications, like it is highlighted here. And the ICI guidelines also say that only do in relevant abnormalities. So the guidelines are there for guidelines only, but they should not, but one needs to modify them according to the local needs. Coming to the second aspect, which is the treatment of the neuropathic patients, and I will only zoom in on one aspect which is very relevant is, I'm sure that most of you will be aware that a neuropathic patients, generally we institute them on self-intermittent catheterization. And if you look at the EU guidelines, which are the most respected ones, it says that it should be started, and it goes on to describe in great detail what catheter should be used, what the frequency should be. So as far as the EU and the international guidelines are concerned, that is the only method of bladder drainage. This is a very interesting paper. It's hot off the press from India in Spinal Cord 2017 September issue. And they surveyed the local Indian population and also the Asian network, and actually found out that about more than a third of the experts recommend patients to use the reusable catheters, like it is enumerated here. Similarly, they can have a clean cotton bag and take the catheter at home, which is obviously is in contradiction to what the international guidelines say. But the reason for that is that 2/3 of the patient will not undergo urodynamic investigations because the facilities are not available. On the other hand, they cannot have self-intermittent catheterization because it is very expensive. As the WHO has agreed with that and said that you can wash the catheter in soap and running water. And guess what? Only 1/3 of the patients do that because majority will have their own way of autoclaving, cleaning it, Dettol, Savlon. Every patient will use whatever is convenient for the patient in an individual setup. It's very interesting that looking at that trend, there are lots of studies happening in the developed world looking at the cost implication of self-intermittent catheterization, and this is a very good study from Mothers Barker, which shows that in 28 spinal cord injury patients, followed them up for 3 years, and the recommendation is that the reusable silicone catheter is as good as the disposable one, and actually self-intermittent catheterization with reusable catheter may be a suitable and safe choice if it can be used properly. So the guidelines say the self-catheterization should be a standard, but actually the evidence says that you can reuse the catheters.
10 minutes, sir.
That's last 2 slides. And if you also look at the guidelines, they don't actually agree with each other. In the treatment, this is the EAU guidelines, this is the BAUS guidelines, and I did this work for a British Journal of Urology, that the guidelines do not actually agree with each other. Similarly, the last slide about the surveillance, which was the follow-up, again, the guidelines do not agree with each other. And I think it's all very well to have the guidelines, but the guidelines should be tailored according to the individual needs. So in summary, Mr. Chairman, are the guidelines true standard? Probably yes. Are they universally implemented? Probably no. Evidence they improve the outcomes? I don't think so. But should they be followed? Probably yes, in the context of increased awareness, prompt management, treatment strategies according to the local facilities, cost effectiveness, but lifelong follow-up is required. One should collect the data and then collaborate with regional and international centers. Thank you very much.
Thank you so much.